Hello, and thank you very much for listening in to this poster presentation, What to Consider That Ensures Quality Health Outcomes When Using Point-of-Care Ultrasound. I am Dr. David Weber. I'm a professor of medicine, pediatrics, and epidemiology at the University of North Carolina in Chapel Hill. And again, I want to thank you for listening into this important conversation. By way of introduction, ultrasonography constitutes an integral part of modern patient care. It forms part of the treatment algorithms for the management of cardiac arrest, pulmonary emboli, central vascular device insertion, and guides hemodynamic assessment in common clinical syndromes such as sepsis and ARDS. To achieve the full benefits in patient care that ultrasound brings to emergency and critical care, clinicians need to minimize the contamination risk from the use of ultrasound probes and machines that are shared medical devices. That is, they move from patient to patient. What we've done here in this poster is a literature review of various surveys and research studies in ultrasound probe decontamination that has showed the risk of cross-contamination through the repeated use of probes as a vector for pathogen transmission in evidence-based research. The survey studies provided further insights into the practicalities, infrastructure requirements, and limitations of implementing infection prevention process without dedicated guideline and medical staff training. Let me now turn to some of the results of our surveys. In the early stages before guidelines were established, a number of clinical surveys of sonographers and radiologists highlighted inconsistencies and lack of sufficient knowledge or training of proper cleaning and disinfection procedures, including clinical workflow challenges of insufficient time between patients to implement stringent infection prevention measures in busy ultrasound units. For instance, the European Society of Radiology online survey of members assessed control measures for infection prevention in ultrasound. Ruth Carrico survey, which is displayed in the upper right, did a survey of 358 healthcare facilities in the United States and showed the very widespread use of ultrasonography in all of these different specialties. Angela A., their survey showed variations in ultrasound probe reprocessing. And finally, Soderetti and colleagues found that ultrasound probes used in 3 radiology departments had higher levels of bacterial contamination, importantly, and hard to believe, than public toilets and bus poles. Well, the results and the concerns raised by these surveys that infection may be transmitted patient to patient through ultrasound procedures are well supported in numerous published literature. Poor infection prevention practices can be contributed to medical staff perception that cross-transmission risk of infection is negligible if an ultrasound traducer has been covered with a single-use sheath for the procedure, then receives low-level disinfection that would, some believe, provide sufficient protection against pathogen transmission. However, this is not true, and we should be using high-level disinfection. As you can see in the lower right box, patients are 41% more likely to have positive bacterial cultures 30 days after a transvaginal scan where probes were low-level disinfected, and 20% more likely to be prescribed antibiotics compared to having probes that were high-level disinfected. I'm not going to go through all the studies listed here, but a retrospective study revealed an increase in infection risk in 30 days following transvaginal ultrasound. A research study conducted in 5 emergency departments and ICUs showed that handle and cable sections are exposed to cross-infection risk. And with quick turnaround times, performing 10 to 35 blocks per day, including single-shot injections and catheter placements, it's really not practical to move probes to and from the central sterilization department for disinfection, which is often not available in clinics in any case. So moving to our second results page, the rapid expansion and the use of point-of-care ultrasound has brought clinical benefit, but may be exposing patients to avoidable infection risk. The lack of consistency and high-level disinfection practices and poor adherence to high-level protocols further supported the need for dedicated guidelines to adopt and expand the 2017 ASUM ACIPC guideline for reprocessing ultrasound transducers. In 2020, the College of Intensive Care Medicine Ultrasound Special Interest Working Group published a set of recommendations for the prevention of pathogen transmission during ultrasound use in the ICU, and I highly encourage you to both read and follow these guidelines. These recommendations consider the medical, administrative, financial, and practical controversies surrounding implementation and addresses emerging issues of care for patients with confirmed or suspected COVID-19. And you can see here some views of those two important guidelines. So in conclusion, ultrasound technology has great promise for improving patient care and patient safety. However, it is important that we minimize the risk of infection from contaminated probes. Procedures involving ultrasound are increasingly common, and the complexity of high-level disinfection in certain settings influences the entire work stream and may have both intended and unintended consequences that must be anticipated and addressed. A national survey of infection prevention has showed a wide range of ultrasound use in their facilities. To ensure safe practice in ultrasound use, there is a need for standardization and staff training, ultrasound probe and cleaning, and again, adoption of high-level disinfection practices. And these guidelines in this webinar further highlight the complexities of ultrasound in intensive care and emergency environments. So in conclusion, thank you for watching, and I appreciate your time. Attached to this poster are a number of excellent references, which I encourage you to read. Thank you very much.